Well, good morning. It's really nice to be here. And the one thing I would say, Julie, from your list, which I thought, by the way, was fabulous, I've always had trouble with that sense of humor thing. I have a daughter who is 16, and when she was very young, I'd come home from work, and she would say, "So, what's the funniest thing that happened to you today?" I'd be like, "Oh my God." It would really, I'd be coming home thinking, okay, what was the funniest thing that happened today? Find something funny. And then I would come in and I would think of something remotely funny, and she's like, that was not funny at all. You need a sense of humor. So with that, that's my disclosure. Julie, congratulations to you, and thank you for all the leadership. Like Julie, reason to be here at this moment in time is in part a sense of urgency, the moment in history that we're in. I think my first AMWA conference, I was probably a fellow, in my residency program, and I've stopped in and out, but you're in San Francisco, and so I consider it an extraordinary pleasure to be with you today. And I'm happy to talk about sort of the first women in these jobs. Julie's done many of them, and I thought all of her summary there was really right on. What I want to do today, I have no conflicts of interest and nothing to disclose except that I'm dismayed at the health policy environment that we find ourselves in this country. I'll disclose that right up front. But other than that, I have no conflicts of interest. Tell you a little bit about the California Healthcare Foundation. We've been around for about 20 years. The foundation was a conversion foundation from a not-for-profit health plan that became a for-profit health plan and endowed this extraordinary organization. Our mission is really very clear, to make the delivery of health care work for the people for whom it works least well. So we have a very specific focus on the care delivery system, how to make it more value-based, but with a particular focus on the most vulnerable, and a lot of the work that the foundation has done over the years has been in the health policy arena. So Julie was talking about heroes and heroines. And so this is a story of Pauline's Perils. Interestingly, AMWA was started in 1915. And Pauline's Perils was in 1914. It was a mini-series where the heroine was attacked by pirates and all sorts of folks, and at the end of the series, she would endure and survive. So I thought that a little reflection on Pauline would be worthwhile today. Want to spend a minute on the ACA. Many of you may have seen there was a very interesting New York Times magazine article back in February. The cover was sort of the future of ACA. It was written to reassess what the mantra had been that made ACA the enemy of people. And it really is a fascinating read about how messaging, anything you don't like about healthcare, that's Obamacare. So what I wanted to do today was unpack really what was in ACA and is in ACA even today as it is the law of the land. I'll take it through the lens of California because we do a lot of work in California, but it is important to note that every state implemented ACA slightly differently. And if you take the train metaphor, I grew up in the desert Southwest in a small little railroad town in southern New Mexico, and so trains are always my image. California was the lead train in ACA, and I want to sort of talk about what's been accomplished there, because people can give anecdotes all across the country about horrific increases in premiums and the like, but it's important to sort of keep a big picture on what's possible if you embraced it and implemented it with enthusiasm. So 1 out of every 3 Californians today is now enrolled in Medi-Cal, our Medicaid program in California, 1 out of every 3. And if you go to Fresno or Madera, the Central Valley, 1 out of every 2 people is on Medi-Cal. And all over the place, right? As Julie said, 1 out of every 2 kids are on Medi-Cal in California. So the expansion of Medicaid, which you remember the Supreme Court said, you can't force states to expand Medicaid. It became a voluntary part of ACA to be determined in governorships across the country. 36 states actually expanded Medicaid, 18 of them by Republican-led state houses. So in fact, Medicaid expansion is bipartisan, you could argue. And then lastly, the regulatory components of ACA was designed to try to create an actual competitive marketplace. We could talk about single payer and Q&A if you'd like. There's a bill been introduced in California, by the way, to implement Medicare for all or single payer. But the purpose of this is really to talk about structuring regulations that allowed for an individual market to be created. So if you make more money than you're eligible for to be in Medicaid, and you don't have employer-sponsored coverage, this is really the place to go online to be able to shop, buy premiums with a comprehensive set of benefits. And so the regulatory component of regulating the individual market was a very important part of the ACA. And the other thing is the standardization of plan design and really importantly, essential health benefits, which I want to spend a minute on. California decreased our uninsured rate into single digits. This is probably the greatest decline in the uninsured of any state that expanded Medicaid and that embraced the ACA. And even in the nation overall, the lowest rate we've ever had as a country of uninsured at 8.5%, and a full 21 million people who did not have health insurance pre-ACA today has comprehensive benefits and health insurance. This was really the problem that we saw manifest about a week ago. And then the other thing I want to talk about is the other really important principles and tenets that were embedded in the ACA. And that was the notion of elimination of preexisting conditions as a rider for underwriting health insurance. Today, if we went back to high-risk pools and sorting the people who have preconditions, about 35% of the population would be deemed to have a pre-existing conditions for the purposes of insurance underwriting. So the notion of ACA, which was get everybody in the tent and spread risk, was principally about making sure that you don't know what risk you're going to have, right? A friend called me the other day, woke up, had a seizure, got a CT scan, has a brain tumor. Could not have in any way anticipated that when she bought insurance 3 months ago or 6 months ago, right? So this pre-existing condition is a very important principle embedded in ACA. And in any conversation about any reform or repeal, that's something to keep an eye on. And then very importantly, one of the most profound things I think the ACA did was to fully integrate behavioral health and substance use disorder with physical health. Really sort of sounds self-evident, except we have not done that. We did not build a system to take care of people when they have episodic mental illness, mild to moderate mental illness, or serious mental illness. We have created completely fragmented systems, completely financed them in different ways, and we wonder why mental illness remains so stigmatized as it does today. And so, very importantly, this notion of essential health benefits and the collection of those benefits was principally also about connecting the mind with the body and having our delivery system begin to function that way. Now, I'll tell you an anecdote because, as Julie said, it is important what happens in your family and how you learn from that. I mentioned we grew up in a very small little rural town in southern New Mexico where there was not a regular doc, and even today there's a doc that comes every other week to this little railroad town. I have a cousin who's my age, who's a paranoid schizophrenic, and he has been living with an elderly aunt. It's also his aunt, it's not his mother, there with her for, since his parents died. And I'm the physician in the family. People call and say, what are we going to do? My aunt is now 94 years old. And parens, he's never been in a psychiatric hospital. He's never been on a psychiatric med. He's never been in jail. He's never been in an emergency room. He's also never seen a primary care physician. Okay, so I get the input calls from my cousins. What are we going to do? What are you going to do, Sandra, when we have to figure out how to care for him on an ongoing basis? Well, what happens is instead of getting a call about my aunt, we get a call about him. He's had a stroke, was taken to an emergency room about 100 miles away, and his blood pressure, I think, on admission was 230 over 180. He'd never been in a hospital, never been on psychiatric meds. I had a local cousin help him get there, and I got a call from the emergency room physician to get the family history. And he says to me, so do you have a next of kin? I said, well, he has no parents, he has no kids. It's us, first cousins. We have a lot of us, we're spread all over the country, and we're it. And he said, does he have a primary care doc? And I went silent, because the answer is no, he does not, and no, he has not. And here I am, a primary care doc, and I have a family member in very rural New Mexico on no benefits, had never been on Medicaid, and now has a whole list of medical problems in addition to his paranoid schizophrenia. And that really is, that's a story that goes on all across this country. And so as we think about these benefits, we need to tie them to the realities of families that are trying to cope with these kinds of conditions on an ongoing basis. And then there was a ban on lifetime benefits in terms of costs, and that's another very important provision of the ACA. I wanted to spend a minute on women's health. You probably all know this, but I would say two things. The significant and dramatic reduction in out-of-pocket costs for an array of preventative services, everything from breast pumps to contraception. This has also been an extraordinarily important part of the essential health benefit package that's embedded in ACA. And notwithstanding all of the conversation that goes on about Planned Parenthood and funding there and kind of that ideology, in ACA are an extraordinary number of services that allow women, and in particular low-income women, to be able to access very basic preventative screening services at no out-of-pocket costs, which we know in very low-income families, the more out-of-pocket costs you have, the more barriers you have to care, right? Very simple. So we had an election. Turns out elections matter, right? That was a big take-home. But I'll tell you, you've all, and we talk about this more than we probably should therapeutically. But I will tell you that right after the election, I was driving to my daughter. There was an event at my daughter's school. I was getting from work, trying to get to the Be a Good Parent show up, and I heard on NPR a young woman at UPenn who had voted for the first time in Obama's second term. And the reporter asked, and she was a graduate student at UPenn, and the reporter asked her if she had voted in the election. And she said she did not. And he said, well, is there some reason for that? Is it that neither of the candidates were, met your, and she said, oh, no. I mean, Hillary Clinton by far and away was the most qualified person to be president. And he said, but you didn't vote. And she said, no, she just wasn't that charismatic, and I got busy that day. So elections matter. I'll just tell you, in the spirit of family, I have a lot of second cousins because we're a big Latino family, and that's the way it is. I sent them all an email and said, hey guys, this is now your generation. This is now on you. I mean, I'm going to continue to do my work. I'm going to come to AMWA. I'm going to do a talk. I'm going to do my work at the foundation. But at the end of the day, this is a generational thing, and now it's on you. And I got some responses and some not. The responses that I got immediately was, I voted. The ones I didn't hear from, not so much. Elections matter. So if you read the New York Times piece on how Obamacare was discussed over the period of 7 years that it had become law. It's interesting that when you have this repeal, replace mantra, what people come up with. So this really just does a little bit of a side-by-side, really trying to show you what the ACA did and what a CHCA would have done had it been taken to a vote, which, as you all know, it did not happen. But the one thing I want you to not lose sight of, because it is probably the most profound issue at risk, and that is a 50-year social contract that we have had in this country about an entitlement program for low-income people to be able to access care. Beyond all the rest of the noise, is this an entitlement program for which the federal government in partnership with the state is going to guarantee coverage? Because the Medicaid program is a counter-cyclical economic program, right? As you get downdrafts or recessions or worse in the economy, the demand for the program goes up, right? More people are unemployed, more people with limited income, more need for a program. So economically, it's a counter-cyclical program. And the most fundamental aspect of Roll This Back was about eliminating it as an entitlement program. And it has been an entitlement program since we passed Medicare and Medicaid 51 years ago. That is, I would argue, one of the most important policy issue that faces us at this moment in time. Is it an entitlement program or is it not? This particular bill that never moved forward would have created what's called per capita caps, which would have said, we're going to give you X amount of money on some methodology, what year, how do you do it, what states, all the states get different rates, it's a very complex formula. But fundamentally, the financial risk for expansion of this program would have rested with states, which would have meant whether you're in Alabama, or whether you're in Mississippi, or whether you're in Arizona, or whether you're in California, would determine whether or not you would get a comprehensive set of benefits, whether you'd be eligible or not, whether reproductive health or behavioral health is covered or not. By the way, if you look at the history of Medicaid programs and their contraction and expansion, one of the things you'll see is as they contract in benefits, it's usually the last benefits covered are the first ones out, which means if state had to contract, they'd lightly contract on behavioral health and substance use disorder, right? I'm a primary care doctor. I always tell this story that if you do a week-long CME course in primary care updates and internal medicine, whatever it is, you have 5 days on Friday, just before everyone's leaving to go wherever they're going. There's a 1-hour course on what antidepressants to use, maybe. Now there's probably a course on pain management, re-educating us on the use of opiates. But really, we have not comprehensively trained primary care to be able to see a whole person, right? So this whole notion around, is this Medicaid program an entitlement program or not? Yes, the insurance market and what the regulations are for that segment of the market is important, but it has a very strong, powerful lobbying voice called insurance companies, right? Because they want and need market share, and they will demand some kind of regulations that allows them to plan. The voice for the entitlement program of Medicaid, a mix. Who is that voice? So, in addition to, okay, so that bill didn't pass. There's still conversations. Will they come back at it? There's a lot of ways to create pain in ACA. You could make it a self-fulfilling prophecy and underfund it and not support the subsidies that allow people to be able to afford the premiums. There's a lot of ways to undermine the bill. And then a budget got introduced. And now I sound like Debbie Downer, Julie, so I'm going to have to figure out the joke at the end of this. But what I want to say about this is a reduction of 16% of the Health and Human Service budget has been proposed. And very importantly, the NIH budget has the largest budget reduction in the history of the agency. And if that were to stick, and by the way, scientists as advocates, interesting, think about that. Earth Day's coming up. There are science rallies all across the country. This would be a good time to go talk about the importance of science. But if these NIH cuts happen at this level, there will be a generation of scientists whose science funding from the NIH will be severely contracted. And that's one of the things we should keep an eye on. There are many other things in the budget. There's cuts to the CDC. There's cuts to the HRSA budget, which funds all of the community clinics. The Agency for Health Quality got rolled in to the NIH, sort of completely eliminated as a freestanding agency. So this budget plan is something that is important to watch. And this just shows you in comparison over a long period of time the kinds of things that are being eliminated. And this gives you an idea. One thing that's important to note is that the discretionary part of the federal budget is a very small budget. And if you don't go after entitlement programs or Social Security or programs that are otherwise part of the social contract of this country, you end up tweaking. So we cut CDC dollars, or we cut prevention dollars, or we cut NIH dollars in order to be able to pay for drones and walls. And not a virtual wall, by the way. There was, in the midst of all this doom and gloom, a very important report that came out of the National Academy of Medicine. And I really want to end with this, because this was a series of about 150 scientists that came together in anticipation of helping inform a new administration about what are some of the principles and opportunities that we have at this moment in time to actually improve the quality of life of people that we have in the country. And what I've called out here are a number of those, not all of them. I commend that report to you in its entirety. It has an enormous amount of very thoughtful recommendations about how we think about everything from population health to closing disparities, to the use of data, to the use of technology in care. But these, I think, are some of those that matter most. One, of course, is paying for value and not for volume. We're certainly on that course. It's a nascent part of the course. I would argue, if you're a runner, the steepest hills are still in front of us, so keep running, pace yourself, but that is the right direction to go. This issue about core metrics is fascinating. In California, if you talk to a comprehensive delivery system and you look at all the different programs that fund them, all of them require different metrics to be reported. And it's no wonder that we don't make great progress on key metrics when you've got 100 of them, or 110 of them, or 5 of them, or 7 of them. And the attention span for these delivery systems to be able to organize ourselves to be able to do that. And so measuring what matters most and having us do that in a uniform way by purchasers is one of the compelling reasons for this conversation that's now being instigated about the value of having a single payer. Because if you have a single payer, that payer decides what's important to measure, and then all the systems would measure that. Core metrics, a really interesting piece. This modernization of skills is an extraordinary piece. As Julie said, the future is in this room. I'm so glad that you're better at technology than I am, or we would really be in trouble. But it is important to say that the data piece and the analytics and working as integrated teams and thinking about people working at the top of their license and how you work with a multidisciplinary group is the new skill set that we need for success in the future. And then, of course, we need integration. We talked about that, right? These are whole people, their lives are whole, and we need to make the systems easy for them to navigate, particularly for those for whom it's most difficult to navigate. And then, of course, keep learning, keep generating new knowledge, keep science coming, and innovation. So we're back to the perils of Pauline. And you remember in the last picture of Pauline, she was being kidnapped by a pirate. It really wasn't clear she was going to survive. And if you see her now, I would say she's still working at it, and pirates will not get her. The series of the perils of Pauline, there are many perils out there. Pauline, I have great faith, will persevere. Thank you very much. Nice to be with you today.